Welcome to our webinar tonight about residency expansion facts and myths. We have three great panelists today who will be explaining, the background, and we'll go through some questions, some situations, and then we'll take questions from the participants. And we'll last like 10-15 minutes. So we ask that you leave questions to the end of the entire session, but you can ask questions at any point, and we'll try to get to them at the end. But I'd like to thank our participants, Dr. Fallett, he's an attending at the Pacific Cancer Institute, Dr. Pan, resident at MD Anderson Cancer Center, and Dr. Stevens, who's the chairman at Beaumont Health. And I'm Karna. I'm one of the PG4 residents at Beaumont Health who will moderate this session. So to kind of start off with, we're going to go with some background just to get an idea of what residency expansion is and get an idea of what's happening. So what would you say is the history of residency slot expansion over time?
So I can take that one. There's a figure in the paper that we just put out that's published online in the Red Journal that takes a look and plots the number of spots over years. And if you go back to 1993, there was about 140 spots, and then in 1995, residency got expanded the number of years, so it went from 4 years to 5 years. It's dropped people down, so it dropped to a low of just under 100, and then basically it's been steadily climbing ever since then. So from about 2001, 2002, all the way up to present day, we've essentially doubled our number of residency positions by year.
Okay. All right, perfect. And so, why did the spots increase kind of from 4 to 5 years, or what's been happening?
So I was not in radiation oncology at the time. It's a tough thing for me to answer directly, but Anthony Zeitman spoke to this at the panel that was done at the last ACRO meeting, and as he explained it, it was in part due to poor job prospects at the time, and the thought that if you could increase the length of training, it would delay entry and it would at least ease that transition into the workflow. And it seemed to have a positive effect in that regard, albeit now we have to do an extra year of residency. There may have been some other rationale as well. I don't know if Craig or somebody else can speak to that.
Well, I wasn't involved in the decision making. But I remember the discussions that many of us at the time, and we understood that the sort of the amount of information that people were expected to know had increased quite a bit from back in the old days when you treated prostates with 4-field box to 66 gray. The level of intensity of the training, the detail of knowledge, the number of publications and things that you needed to know to make good medical decisions had increased quite a bit. Also, there was a general interest among the academic community to increase the opportunities for research, and by adding an extra year to training, it was thought that there would be more opportunities for residents to find the time to do the research. And turns out that it looks like that was the case.
So what is the ACGME's role in radiation oncology residency approval?
So ACGME accredits programs. That's basically it. So they don't have any power or ability to try to limit the number of slots. That's abundantly clear. There would be massive antitrust concerns associated with the ACGME coming in and trying to limit spots because of a projected mismatch between supply and demand. So they're simply looking at the ability of a training program to train a competent graduate, and that's it. So they have a lot of power because no other body is out there controlling the spigot and controlling the number of radiation oncology residents that's released. Effectively, they do that because the program can't expand unless they get ACGME approval.
Okay. And then what are data suggesting a surplus of physicians? How good is the data right now that we've collected?
I can speak to some of that. So Ben Smith published an initial paper in the JCO in 2010, and we updated it and spoke about the results preliminarily at ASTRO last year, and then published an update in the Red Journal earlier this year. Just briefly, I think probably a lot of folks on this call have looked at those manuscripts, but basically to estimate the demand for radiation services, we use the U.S. Census data to look at what the population makeup is going to look like in the future. And then we use historical SEER data to get a sense for how these different age, sex, and race strata use radiation therapy, and use that to determine a radiation demand. Then on the supply side, we got basically a list of all the currently practicing radiation oncologists, some results from a workforce survey to determine who's full-time versus part-time, and then use data from the NRMP about the current set of residents and some assumptions about the residency class sizes in the future, and then applied a life table from the U.S. I think Center for Disease Control's, people die over time and people retire, just to estimate what is the change in the number of practicing physicians we would expect. And so when Ben published his initial paper in 2010, the projection was largely due to an aging population from the baby boomers. Demand would increase for radiotherapy about 22% from 2010 to 2020, but in contrast, the supply of radiation oncologists would only increase about 2%, and that was an assumption of the residency class sizes staying at around 140, which they were at the time. And when we redid the analysis last fall, we basically used the exact same methodology, slightly different data set for the workforce because we used ASTRO membership data rather than ABR, which we used previously, but otherwise the same methodology. And demand for radiotherapy was relatively stable, and that was projected to increase 19%, although slightly less than before. A lot of that was largely due to decrease in treatment of prostate cancer and just overall a slight decline in overall radiotherapy use. But the big change was that the projection for the next 10 years in terms of supply of radiation oncologists would go up about 27%. And that was largely due to the fact that, we basically at this point, the most recently matched class size is about 190, and whereas his assumptions back in the initial publication was about 140. The couple limitations to keep in mind using these data is that SEER only includes patients who get radiotherapy as part of their initial treatment. So it doesn't capture radiation that happens in the salvage setting or after progression. So if there's a greater change in definitive versus salvage or later radiotherapy, may not be captured. The goals of these two papers were to try and model relative changes over time. So you have to make some assumptions about what do you think the current supply-demand balance is, and whether this this relative change over the next 10 years is the right thing or not. Something which we may touch on later is that this notion of supply of the number of physicians versus the capacity for these number of physicians to see patients. So if we do more hypofractionation and the planning isn't a lot more complicated, you get increased throughput on your machines and your physicians with the same number of physicians seeing more patients. And then the other thing which to think about as we think about possible things to do in response, the limitation of this data is, the SEER data, or whether you use claims data to estimate demand of radiotherapy, that's always at least 2 or 3 years old. And then if you, say we even had a mechanism to change the spigot for residency numbers, that doesn't take effect until 5 or 6 years down the road because all the, all the existing residents have already been, all the classes have been populated. And so it's a really delayed effect when you're looking at data that's 2 or 3 years old on the demand side. If you're going to make any supply changes, they won't even take an effect till 5 or 6 years down the road. I think that's a challenge, even if we were able to do something about it.
All right. Dr. Fayala, you came up with a new paper, a recent one that was published, the Radiation Oncology Job Market, the Economics and Policy of Workflow Regulation. Can you give us a background or some information regarding that?
Yeah, that was analytical commentary that kind of goes through all the issues that are related to this. It's supposed to accompany Dr. Pan's paper and kind of put everything in context. So there's so much to discuss there, and I'm sure we'll touch on it a lot today with questions and answers. But it goes through all the different survey data that's been available to suggest there's an oversupply. And in my estimation, there's really a lack of really good objective data suggesting that we have a job crunch right now. So we have all these anecdotes about people not being able to get good jobs, about fellowship opportunities popping up largely because the jobs aren't there. And those are concerning, and I think the projections that Dr. Pan just went through are meaningful and we have to consider them, but right now in current present day, we don't have great evidence that jobs are significantly worse than they were 5 years ago, 10 years ago, and collecting that data I think is really important. And then there's a whole bunch of other stuff that I went through in the paper, but I think that's largely what you're getting at.
Yeah. And so can you tell me a little bit of what is the data that we have about graduating residents right now?
Yeah, I see. So basically we have one survey that I looked at and I reported on in that paper for residents who were recent graduates, and it looked at the extent to which they wanted to get jobs but couldn't get jobs. And it looks like it's somewhere in the neighborhood of 5 to 10% who wanted to get a position and then ended up taking a fellowship position or otherwise deferring entry into kind of a real workforce position. But it's unclear, you know, they may have just wanted something in New York or Boston or San Francisco and couldn't get it, and so they went into a fellowship. You know, it's really tough to know to what extent someone actually looked for a job. And then there's an older survey that was done by the ACRO Workforce Committee in 2012 that asked people, well, have you looked for a job? Was it tough to find a job? How happy are you, etc.? And it looked like there were some people who thought there was an oversupply of radiation oncologists then, and people who had difficulty getting jobs. But it looked like the main reason they couldn't get it is that they just couldn't get it in their desired area. And also they reported just incredibly high satisfaction scores with their jobs. So maybe it's that these people wanted the right location and the perfect job and they couldn't get it, and therefore they report difficulty with job acquisition, when in reality maybe they're just too picky.
Okay. And then talking about the surplus, you know, who would win or lose from a surplus of radiation oncologists, and how should society view this surplus?
Okay, so yeah, that was a slide that I had in our panel that we did at ASTRO last year. And it's important to note that not everybody loses associated with this. So the people who really come out behind are the individuals who can have their jobs renegotiated. So of course the residents or anybody who's graduating that doesn't have a job yet, clearly if there's an oversupply is going to get pushed down, lower starting salaries, longer partnership tracks, maybe no partnership track, etc. But if you're just an employed doc in general at a hospital system or at a private practice, wherever you're at, and you have a one-year contract and the cost of labor is going down for that entity and they're going to renegotiate your contract, you're not going to get the same increase that you otherwise would have, and you might get pushed out for somebody cheaper. But the people that come out ahead are the ones that own the machines. So 21st Century Oncology or the hospital systems, or also the professional groups that are very entrenched. So we here in Hawaii have a contract for 15 years to staff this particular facility. So we effectively become like an entity that owns machines. And so those professional groups that are very entrenched, and it doesn't have to be contractually entrenched. If you just have great relationships with the hospital, and the hospital will never kick out that professional group because they've been there for 40 years and know all the referring docs, they become quite strong and benefit potentially from this lower cost of labor. So you might see some of those professional groups with lower starting salaries, longer partnership tracks, that type of thing than you otherwise would have.
Okay. And so, you know, what is actually the entity that governs the radiation oncology expansion, and is there any, you know, antitrust concerns associated with doing the self-regulation within this entity?
Yeah, so the antitrust stuff is real, for sure. I was reading some links on SDN about people who kind of questioned whether it was real or kind of made up by some of the powers that be to keep everybody shut up. But truthfully, you know, there would be massive antitrust concerns associated with any self-regulation here. And it makes sense, you know, from an economic perspective, you can't have radiation oncologists guarding themselves. You know, there has to be some other external check to make sure that we don't just keep numbers unlimited, keep numbers down in order to increase our market power and then do so at the expense of patients. So it's not 100% clear cut, but I would be really surprised if anybody would risk it. There'd be a substantial chance of problems. And I've discussed that with some antitrust experts who are, very bright and, are law professors and teach antitrust.
Okay, and so now we're going to go into looking at kind of other specialties and looking at, so if specialties can't legally self-regulate, why are there so few derm spots and kind of other specialties of that, select specialists like that?
I don't know the answer. I can offer a hypothesis, and then, I don't know if the other panelists have thoughts on it as well. I'm not privy to any of the inside information related to derm or neurosurgery or anybody else, but I think there's two plausible explanations. One is that there's just a gentleman's agreement associated with some of the other specialties. I don't know that to be the case, but it's possible that they just all kind of say, yeah, we can't have an explicit agreement to restrict supply, but there's this tacit agreement to restrict supply because it's better for everybody. Or alternatively, and I'm sure we'll talk about this later, it's an important topic, whether other specialties earn less money off residents. So maybe radiation oncology residents are more valuable to programs than other residents are, and therefore expansion has been more dependent on external funding, so getting GME funding, whereas in RadOnc we may have seen a lot of expansion even without those funds because the radiation oncology residents valuable in terms of generating a margin. Or maybe radiation oncology faculty just likes teaching residents more. That's a third explanation, and derives some other non-economic benefit from that expansion and hasn't relied on GME funding because of that.
I would say that's more likely to be the case. It's far more efficient for me to see patients without residents. No offense to the residents on the call, but I can see a patient. I know what the notes are supposed to look like. I can have a templated note, have it done and signed before I can read the note that the resident writes. So it's actually faster for me to do it myself. I don't have to check things. It's more fun to have residents. I really like having residents. Residents ask really good questions. They make our research better. They make us think about things that we might not have otherwise thought of. They help us to think outside the box. And I think having more smart people looking at a case makes our ultimate treatment plans and treatments better. Do I think it's more efficient? No, but it's awfully more fun.
And talking about residents and residency expansion, how about changing allowing providing with more mid-level providers and other people kind of to fill in that space versus looking at that aspect of it?
So if I try to do the right thing for patients and the right thing for society, I think including mid-levels makes a lot of sense. I'm practicing with a nurse practitioner now who's excellent, and it's so much better because it unloads a lot of the time for me to do the physician work. So I spend a lot more time with the planning, the iteration with dosimetry, allows me to see more patients. I provide better care for my patients, undoubtedly, because I've effectively tailored everybody's job responsibility to their training. Whereas I think that's not true in a lot of cases, private practice or academics, where they're not really using mid-levels up to the point where they could be. And that would allow us to see a lot more patients with fewer docs. So if you look at Hubert's paper, and he can correct me if I'm wrong, but that the projections there don't take into account the ability to expand our capacity by using mid-levels or using more technology or whatever it is to see more patients. And I do see substantial opportunity there. The potential downside is that if you give somebody a hand, you worry that they're ultimately going to take an arm, and that eventually there'll be independent nurse practitioners seeing subsets of our patients effectively eating away at our business. So from the standpoint of if you want to take a guild mentality and protect radiation oncology interests, you do worry about allowing for the entry into independent practice.
Yeah, I think nurse practitioners and PAs can be very, very helpful. They definitely allow you to see more patients. One of the things that I worry about is that, and one of the things that I value as an academic radiation oncologist is the ability to specialize. So I pretty much just see lung cancers, chest cancers, mesotheliomas, lung cancers, thymomas, those kinds of things. If I was expected to see twice as many patients, they may well force me to dilute my efforts and to become less of an expert. And the addition of a nurse practitioner would not make up for that loss of expertise, even if I had more time to see patients.
Yeah, I agree with that, and I think that's the disease site specificity is something else to think about, because you can never recreate that. I agree with Craig wholeheartedly that no generalist will ever be as good as a disease site specialist, and that's one of the things I've had to struggle with as a generalist. But in the future, my thought is that there will be more disease site specialists as hospital systems consolidate. So you're going to see less freestanding practices kind of floating out there, and more satellite networks where you have physicians seeing patients at 2 different centers, or in some fashion plugged in with disease site specificity, making them more efficient. Because when Craig sees a lung cancer patient, he doesn't look anything up. Presumably he knows it, he's done this a zillion times, whereas I have to see all the patients, so I'm just slower. And if we could move towards that disease site specificity model, we'd all be faster, see more patients, and maybe need less doctors, further exacerbating the oversupply.
Well, and there's some nuances to that as well, because I think that there's not just advantages in the consultation and the treatment planning process. There's also advantages in how I manage my patients. I mean, my nurse and I are pretty good at managing esophagitis because all we treat is lung cancer. So we do that pretty well. I can manage a patient's asthma medicines pretty well because I do it all the time. I'm not managing people's seizure medicines because I'm not a neuro guy. And so the expertise is much deeper than just the docs. It's the people that hang with the docs. It's the nurse. It's my dosimetrist that's also an expert. And so that level of expertise, again, the more you dilute that, I think the less quality of care you deliver to your patients. Or you run the risk for that, certainly.
All right. So kind of, now thinking about, to what extent does a program director chair owe a duty to its program, its faculty, its residents, and the entire radiation oncology resident community? How should a program director / chairman make decisions when serving the above constituents is in direct conflict? If we're talking about residency expansion and kind of the decreasing need for radiation oncologists.
Well, as one of those chairs, I think that we owe it to ourselves and to the future of the field to make sure that all of our trainees have a great experience and get jobs in doing what they want to be able to do. They shouldn't all be getting fellowships or going to train in dermatology because they can't get jobs in radiation oncology. So that's part of our job as chairs, is to make sure that that doesn't happen, and if that starts to happen, that we take fewer residents. I certainly don't want my trainees to be, coming back to me with shotguns 5 years later saying that they can't feed their families. That's not right. I would not do that to people. That said, I think we as leaders in the field owe it to our field to develop novel things that we can do that we can help to feed our families with. So I think that the delivery of radiopharmaceuticals is something that we should be doing in radiation oncology. You could argue that the thing that differentiates radiation oncology from the rest of medicine is doses to volumes. That's really the thing that we do differently than anybody else. And you could argue that we should be doing RFAs, cryotherapies, because that's also doses to volumes. We put needles into things all the time and just put radioactive sources into those needles. There's nothing that says we shouldn't be able to put heat or cold into them as well, again, with appropriate training. I would advocate that interventional oncology should be something that we should be actively involved in pursuing and, in fact, leading.
Yeah.
So talking. Go ahead.
Just speak to, I think that's a great, set of questions and discussion about kind of where a chair owes his duties. And, there's a lot of people out there who think that there's a bunch of greedy chairs out there running around trying to screw everyone over, and I really don't think that's the case. My real opinion is that the vast majority of program directors and chairs genuinely care about their own residents and about the specialty as a whole. But you have to remember that there's a lot of programs out there that are really good, that train residents really well, and whose graduates get great jobs. And if they hear off in the periphery that there's some other programs where the graduates aren't getting great jobs, are these better programs that train people well, that get good jobs for the residents, really supposed to cut back just because there are other smaller programs or programs on the periphery that aren't training their people as well? I mean, the right thing to do is to make this a better market then, to get that information out there, to have data about program-specific employment rates and salaries and progression so that the people coming into residency know which programs are the real deal and which programs don't do a good job, because then nobody will fill those slots at the lousy programs that aren't getting their kids jobs. And then we'll get a better market and those spots will go unfilled. And I just don't think it's the role of a program director or chair to cut back and sacrifice their own program because there are some others that aren't behaving in the right manner.
Well, and towards that end, I looked back at our data from Beaumont, and about half our trainees go into private practice and about half go into academics. In the last 5 years, we've had one radiation oncology trainee do a fellowship because he wanted to do pediatric radiation oncology more than anything else in the world, and he went to MD Anderson. Well, I don't view that as a failure. I think we did well by priming him to be able to do that. And nobody has failed, or nobody has not gotten a job within a few months of the end of their training. So in the grand scheme of things, I feel pretty confident that the training at Beaumont is sufficiently solid, and we have a sufficient network of both former trainees and colleagues that we can make sure that our trainees, don't have to sell a kidney to live. I think we can, we certainly can do that, and all the big programs can. We have 3 residents here. We have an internship, so we have 15 trainees, and they're all going to do fine.
So, talking about the job market, what would you consider an optimal job? I think that, that varies per resident or graduating resident, but should they accept, desired geographical area? Would you consider that a failure if they don't match there, or take a lower entry salary?
Well, I think to some extent that's up to the trainee. I mean, I certainly worked in places that I didn't fantasize about living when I was a young boy in Cleveland, not knowing what I wanted to do. For me, I always followed the work. I went to where the next great job was. And so to me, the geographic area was less important than the quality of the work and my colleagues. But I can certainly understand where some people may want to be close to their parents or close to their kids, and I totally get that. Success, my job is to train residents that are successful the way they view success. It's not up to me to decide what's successful. They need to define that, and it's difficult to determine that from surveys.
And add to that, at least all the counseling we've gotten from graduating seniors, visiting professors, mentors at our program, basically everyone has to decide between things like geography, practice type, disease site, what matters most to you, and you may not be able to find a job that gets you all 3 or 4 things that you want, but if you can prioritize and kind of focus on the things that matter most to you, most people end up happy with what they end up with. And that may be getting back to the survey that Dr. Fallett was referencing, where people, maybe they had the expectation they would get every single facet of the job that they wanted, and therefore said they had some trouble finding a job. But it sounded like everyone was was happy at the end of the day.
Yeah, and just towards that end, I've known people that were really happy that their cup was 10% full, and I've seen people that are really angry that their cup is 10% empty. And you're just not going to be able to. Ultimately, people need to be happy inside themselves with their own decisions, and so the idea of who's happy and who's not, I think no one is going to be 100% happy all the time with their job decisions. Heck, from week to week, I'm not always happy with my job decisions, but we all have good weeks and bad weeks. It depends when the survey comes.
I think the key is that people's expectations coming into it are met to some degree. So if you're coming into a residency program and that residency program puts out information about the job prospects and the satisfaction levels and the geographic opportunities and the pay scales, and that makes sense to you, and that's why you go into the field and try to match at that particular program, and you do, and then things are drastically different, that's a problem. And so it's very hard to define what's an adequate job, as you said. That's why you asked the question. If they can't get it in their geographic area, does that mean we have a problem and we should cut back on residents? I wouldn't say that for sure, but you just want to make sure that all the information is out there and you're up front, and that medical students coming in and trying to match at different programs are well informed.
So I think there's been
about 100%.
There's been an increasing number of fellowships kind of starting. The question is, in general, will fellowship numbers keep on increasing if jobs are not enough? And do we need more regulation for these fellowships? Many of these are not ACGME accredited currently.
None of them are ACGME accredited. Personally, I think that we're starting a proton fellowship because we now have a proton center. I think you start a fellowship when you have something special to teach. So I don't personally plan on starting a fellowship just to keep more trainees around. I don't think that's a good idea.
Yeah, I don't see it as a problem. I mean, people view it as like exploitative, but it's not necessarily like that as long as the fellowship's upfront about it. And I do think it's an indication of a declining job market, at least in some geographies. So like the big markets are tied up, New York, Boston, San Francisco, Chicago. So you'll see these fellowships that pop up. But as long as whoever is offering the fellowship is upfront about the responsibilities, the pay, the opportunities after the fellowship, all of that, I mean, it's an open job that somebody can take, and then you just don't take it if you don't want it. So I don't see it as a problem. I mean, the word exploitative, to me, means that there's a misrepresentation or an informational asymmetry, and I don't believe that's the case for at least the majority of these fellowships.
And do you think we're focusing a lot of people with a lot of research focus. Should we introduce a clinical track that kind of changes the market for more clinical physicians, clinically directed, oriented physicians?
No, says the academic radiation oncologist. I actually feel very strongly that oncology, and I think that you can see it throughout all of oncology, not just radiation oncology, but over the last 30 years, the way that we treat cancers has changed fundamentally. And if you don't have people that understand how to do research, how to read research papers critically, if you don't, and the best way to train people to read critically is to have them write critically. And so I think that it's a very important part of residency training to get our trainees to do research, to even a retrospective trial. Once people have gone through charts and filled out forms, they realize the problems in retrospective studies. And it opens up their eyes to stuff that other people have published and the potential pitfalls. They have a more visceral feel for where the problems are. What statistical tests do you use? What breakpoints do you use? And realize that to some extent it was made up. And that changes the way trainees view research. They see it with a little more of a jaded eye. It's not, we didn't get our research results on stone tablets. And so there's interpretation that's involved. And teaching, young physicians about that and about the nuances is critically important. And the best way to do that, to me, is to have them do the research themselves.
So I think it's nice that we can agree to disagree here. So I really don't particularly agree with that. I think research is very valuable, absolutely. We clearly need top researchers to drive the field forward. My own experience in a very research-heavy program was great. Learning how to read papers, having that expertise for my training was fantastic. I wouldn't trade that for anything. Incredible training. But there's two big downsides to trying to force everybody into research. One is you're attracting predominantly research-focused individuals who want to be in research and therefore want to be in major metropolitan markets and want to go into those types of jobs, and there's not enough jobs for them. And so then they just flow out into the community, and then when they get to the community, they're not as adept at clinical practice, which requires a different skill set than they otherwise would have been had you attracted the right people up front. Plus, there's also an aspect to this about efficiency in the training. And so all training is good. I mean, you want to go get another degree, it's only going to make you a better person. If you want to do an extra fellowship, it's going to make you a better doctor. But how do we train people quickly and efficiently so that they're competent providers in the community, able to provide really good standard of care medicine out there? I'm not convinced that the best way to do that is to have 9 to 12 months worth of dedicated research time, and it probably could be done much more quickly by just learning how to read papers, having didactics on research-related issues, and then getting them out into the clinic, and focusing on other humanistic aspects of clinical care, which are neglected in a lot of research-driven programs.
Perhaps my concern with that is that they're going to be fined for 5 to 10 years until the field at the best centers bypasses them, and then they're going to be at a loss for how to understand how to move their own practices forward, potentially.
Yeah, that's an empirical question. How much research methodology do you need to be able to stay up to date and not just read guidelines? Because you got to be able to read papers. You have to be able to interpret things yourself. That training was very valuable to me. I'm of the opinion you probably don't need a year of it, and you don't need to take people with PhDs and 12 publications, but that's an empirical question I don't think we have the answer to.
No, and I completely agree with that. In fact, I think until we get more NIH funding, having lots of MD PhDs in radiation oncology is a recipe for disaster and dissatisfaction. With NIH funding rates in the 7 to 9% percentile range, that's going to cause huge dissatisfaction among the MD PhDs. So you don't want that, but you want people that are able to adapt rapidly in a high technology environment. One of the things that I realized over the years from talking to some of my colleagues is that if you read a paper today and implement it, you're about 5 years behind the times. So it took about 5 years from the time that concept first came out. So let's work back from the paper that I read today. Well, assuming I read it as soon as it came out, the time from the submission of that manuscript to its publication is probably 6 months to a year. The data had to be collected, which might have taken another 2 or 3 years, and it might have taken a year to actually design and get the trial funded and going. So you're about 5 years behind the state-of-the-art thinking if you're implementing what was published today. So in order to really give state-of-the-art care, you have to be involved in the design of those studies, and you have to know how those studies are put together and how people are thinking. And that requires focus and research-driven mentalities, in my opinion.
All right, thank you. So if anyone has any questions, we'll start collecting the questions in the meantime, but we have a couple more things to go through. In general, who should regulate the market? Should it be medical students, ACGME, program directors, chairmen? Who do you think it would be the best, who needs to regulate what we're doing?
So, I mean, I can speak to that because we tried to answer that in our paper, and it was a really challenging thing to come up with. Basically, in the ideal world, I think we would have some type of top-down regulation. The market is fraught with tons of error here. There's a 5-year lag time. You're never going to have perfect information transfer to prospective residents. Plus, you're going to have some specialties that limit their supply more than others. So if we have all this extra capacity, will we just get spillover from all the lousy medical students who couldn't match in their other specialties because they restricted the supply of dermatologists? So it's really challenging to do this with the market. We should try. We should try to perfect the market as best as possible. But the ideal situation would be have top-down regulation at the multi-specialty level. So some type of board that looks at all the specialties together and tries as best as it can to match supply and demand and try to correct for those market failures. I don't see that as being possible or pragmatic at any point in the future, and we can't really have specialty-specific regulation because of the antitrust concerns. So it's a tough, tough thing. So I think we're sort of stuck saying, okay, let's just try to perfect the market. Another thing that we can look at is, you know, what programs are expanding with and without funding. I think a lot of them are expanding without the funding, but if we find out that's not true and actually they're all getting funding from graduate medical education, general funds, Medicare and otherwise, then we could try to control those purse strings and allocate those funds differently in a way to match supply and demand. But there's really no perfect answer.
And like talking about, I know that previously we were talking about, you know, programs that may not be getting jobs for their residents. Do you think the ACGME should step in and kind of change their accreditation standards to discuss that as part of the accreditation process, making sure the residents are getting satisfactory jobs?
So no, they can't. So as a really important point, I mean, I don't think the ACG can or should act as an end run around the antitrust system. And so if we feel like we can't self-regulate, we can't say, okay, we think that there's an oversupply, ACGME, please step in and change the accreditation standard. As a separate point, and we talk about this in our paper, we should have ACGME just relook at the accreditation standards, because the fact that there is an oversupply, as well as the fact that we have all these fellowships, may indicate some degree of failure there, that we're not actually training people who can go out and practice all disease sites and be really competent. So maybe we need to take a finer look at the case requirements or other requirements for training so that residents are only getting training at the best programs where it's really adequate. But that's separate and can't be looked at in parallel with the supply and demand issue.
Okay. All right. We don't have any questions so far, but if you have any questions, you can go down to the chat box and ask them directly. But some other questions. Now, there's a new oncology care model coming up. How does this impact our field and kind of what we need to do, you know, in terms of residents?
Yeah. So the oncology care model, we spoke a lot about, maybe too much in the paper that we wrote, because it's a dominant way in which payers, including the government, are looking at paying for oncology services. And it's just another way to bundle or package or create reimbursement for comprehensive episodes of care. What the oncology care model does is center around medical oncologists. And so as soon as chemo or hormonal therapy is given, that medical oncologist is on the hook for all the spending that happens in the next 6 months. So that includes hospital visits, that includes radiology scans, that includes radiation therapy. So there's a concern about when you put the center of the payment system around a referring doctor, like a surgeon or a medical oncologist, that they're going to have an incentive to refer less to us or refer to places that are doing more hypofractionation or just treating in ways that are cheaper. So it's going to end up decreasing our reimbursement, decreasing our patient populations, meaning we won't need the same capacity that we otherwise would. So it would exacerbate an oversupply, and that wouldn't have been projected in Ben Smith and Hubert Pan's papers.
Something about that. So do you think we should put more emphasis about teaching radiation oncology to medical students and kind of put our efforts there so that, you know, those medical students who may not do radiation oncology but may do other specialties like primary care, medical oncology actually refer to us and understand referral properly?
They won't remember. Yeah, I think the people that need to be educated are the surgical and medical oncology, the surgical oncology and medical oncology trainees. They need to be educated on sort of when, actually two things, when to send patients to radiation oncology and how to pick a good radiation oncologist.
Yeah, we definitely need to do a better job of training our primary care docs and letting them know what we do, but I don't know if the medical student time point is the right focus. But in general, the more that we can bring ourselves to the forefront and show that we really do think about patients and care and take a holistic look and, don't just dispense radiation, I think, there's been a lot of people talking about that forever, Anthony Zeitman especially.
So I think one of the things that comes out is, what would your advice be for future medical students who are applying to our field? Should they worry about this potential job issue? Should they not apply? Should they look for other fields? Kind of, what would your advice be, if you had to mentor a student right now?
I tell people that they should follow their hearts to a large extent. Radiation oncology I believe to be a great field. We do a lot of medicine. We manage a lot of sick patients. That's a very rewarding thing. We spend a lot of time at a very intense time in a patient's life when they're undergoing cancer treatments. We see them at least once a week, sometimes more, for months, and then we see them in follow-up for years. We develop real relationships with our patients. We also have really cool technology. We get to do a bunch of imaging. We get to do image manipulation. I would tell people, and there's also humongously interesting research opportunities, though our field is really quite old in the scheme of oncology. The first patient was treated with radiation therapy over 100 years ago. There's still a lot of unanswered questions. How should we integrate novel biologics into radiation treatment? How should we best minimize toxicities? Those are all very important things that are very cool. How can we develop new radioactive drugs to deliver high doses of radiation just to where the cancer is? Very cool opportunities to do very interesting things. And if you're excited by that, then radiation oncology could be a good place for you. So, I mean, you don't want to discourage people that would be good for the field and whose interests and skill sets match with the field, because there's going to be jobs for the people that are the best at what they do.
Yeah, I am incredibly happy in radiation oncology. I mean, I couldn't imagine another field where I'd be happier either inside or outside of medicine, and I say that with the utmost sincerity. I mean, my day-to-day basis is incredibly intellectually driven. I'm thinking about complex cases. I'm doing really deep brain work all the time, thinking about cases. I meet patients and their families who are incredibly grateful and have personal connections that go on top of that intellectual aspect of things. We're still compensated reasonably well, I mean very well, and lifestyle is still excellent. I think there will be job opportunities. The big thing that people coming out have to take into consideration is just geography. You know, it's very possible that big desirable markets are going to be tied up for the foreseeable future. That's my expectation. I don't have a crystal ball. That might not happen, but it does seem like things are going in that direction. And if radiation oncology is a good enough field to overcome that for you, then you should still do it. It would be for me. I would never do anything different if I had to go back again, even if jobs were tight in those desirable areas, because the field is just that cool for me.
And talking about the tight, areas that are not desirable, do you think, how can we incentivize, or what needs to be done to kind of address this and push residents, to these areas?
There's no easy answer to that. One thing is they can pay more money, So this came up at the panel that we did last year at ACRO, and someone, I think from Iowa or somewhere, spoke and said, we can't recruit anybody to our job. And I didn't ask them how much they're offering, but eventually, if you pay somebody enough, they'll go to the rural markets and get drawn away. That amount may be high enough that it's not worthwhile pursuing that as the best policy option, because people may require such a huge delta to get them out there. But loan forgiveness is a good way to do it. So some sort of, a specialty-wide collection and distribution of funds that would pay off debt, because people tend to disproportionately weigh their debt. So in reality, if you're a radiation oncologist and you're going to make a lot of money over the next 30 years of your career, you shouldn't really care that much about 200 grand worth of debt. You should, if you care about making a lot of money and coming out and being the most financially successful, you should just get the best job you can. But people disproportionately weight their debt and think of it as just a burden on their shoulders. And so if we can take advantage of that psychological heuristic and pay off people's debt to get them to the Midwest or to the less desirable areas that have had trouble recruiting, that may be beneficial for everybody.
And then also with the new payment model, how do you see that affects practice radiation oncologists and hiring new radiation oncologists? Do you think that there will be another down spike, when the pay model is going to come out?
So I think part of the reason that there is it is more difficult to get jobs now is the same reason that it was more difficult to get jobs when they were talking about Hillary Care back in the day. The jobs dried up for a couple of years when Hillary was working on her plan with Bill back in the day. There were like 2 years where it was just, there were no jobs. The same thing is going on now. There's so much uncertainty with new payment models, the Affordable Care Act, that people who might take on a partner are holding off until they see how things go. I'm not sure that once the new payment, once we can predict what's going to happen from year to year, we may find that there's more jobs than we think, because you can only beat yourself up for so many years before you get tired, and you can delay that extra person in your practice for a while, but not forever. And so I think what we'll see is that the job market will open up as people get tired.
Yeah. So looking at the question, it looks like two parts. So how is it going to change how we practice radiation oncology? So I do think there's going to be more of a shift to hypofractionation. I mean, it's not real rocket science that if we shift in some way to either incentivize our referring docs to seek out the cost-effective treatments, or we're getting lump sum payments instead of fee-for-service, eventually we're going to have to transition to more hypofractionation, look at SBRT more, try to do things in a more cost-effective manner, as opposed to the old way where every single click made extra money, every bit of technology made extra money. So I do think that there will be a change in the way we practice. It might be slower than some people think. So, oncology care model is up and running now. You're not going to have early results for many years. These types of payment models iterate over time. They initially start in big locations and then diffuse. Yeah, there's a piece of legislation called MACRA. Not that important to go into the details, but it may push us faster in that direction. But I still think a lot of places are pretty far out from this transition, and we'll have many years of kind of status quo in a lot of locations. And then in terms of hiring and job opportunities, it's very tough to tell. You have to think that it's not going to help jobs, but if it's moving in the direction of hypofractionation, it may really hurt things over the next 5 to 10 years.
Well, we actually looked at the number of fractions per patient on treatment, and the average number of fractions per patient has fallen by about 1 per year for the last 6 years. So, of course, that's across all the patients that were treated in our system, but I think that's indicative of where we're headed. So the addition of SBRT, Canadian fractionation, for breast cancer, I think all of those things, and also new data on palliation to suggest that you probably shouldn't be given 4 weeks of radiation therapy for palliation. Maybe 1 fraction is enough. So I think as we see more of that, that our numbers are going to go, the number of patients on treatment are going to go down.
Yeah, I think a lot of that is just driven by data, though, as opposed to true reimbursement changes for you guys, right? I mean, the question is, when are the reimbursement changes layered on top of the existing data supporting hypofractionation really going to push us in that direction? And I don't know, that may take a little longer.
Yeah, today we're doing hypofractionation because it's the right thing to do, because we get paid less to do it.
Right, same here, right? I hypofractionate my breasts even though it adversely affects us. I do it because, I don't want to bring patients in for longer.
And the other question is kind of going with that is, if there's a payment model change, do you think people would want to prefer academics or private practice, or like a private practice group with a medical oncologist associated with it, because of if the med oncs hold it, you want to be associated with a medical oncologist?
Yeah, all good questions, and I think it really depends. So there are some private groups that in this setting are going to really thrive if they have the right connections, and it doesn't necessarily have to be full integration, but if they have the connections with the referring doctors in some fashion. And those groups just got a lot more valuable. So you're looking at a partnership track, and if they're charging the same effectively by giving you a 4-year partnership track and same salary as they did 20 years ago, then they're probably a good buy. But there's other groups that in this new payment system, because they need to secure those relationships and they haven't done it, or they're not as contractually entwined with the hospitals, that are very likely to fall apart in the next 10 years. Now, their stock just went way down, and if you're buying in for the same partnership period with the same salary as they were 20 years ago, then that's problematic. The key is to try to figure out which practice is which, and it's really tough to do. There are some that are integrated with med oncs that I don't think are well prepared to function in the upcoming payment changes. And there are some radiation oncology specific practices, especially in geographies where oncology care model doesn't apply, or that are more rural in general and haven't been faced with the same pressures, that are poised to thrive still. So it's really tough to answer on a webinar. You got to get good expert advice from somebody who knows and understands the economics, and you can't just jump into jobs unless you understand everything. And I see a lot of radiation oncologists do that. You have to just ask people who know and make sure, if you don't know something, figure it out and get the information from your employer or a friend or somebody, and try to make the best decision.
All right. Thank you to our panelists for joining us for this webinar. Is there any last comments before we end the webinar?
Thanks for listening.
Yeah, thanks for having me.
All right. Thank you, everyone. And we will now end the webinar.